Sir, you can start now. It has been started.
Okay. Good evening, all of you. This is a follow-up of whatever topics which has been covered. Now we have the hospital infection control. As you all know, just I want to give a little preamble to the whole thing. We know that there is the news edition which has come. So when the new edition came, we also looked at where the changes have been made, and wherever the changes have been made, either to one, raise the bar, two, to bring more clarity or reduce ambiguity, or rare cases where it is already addressed somewhere or it is redundant, then that was removed or that was sometimes deleted or modified. With this few introduction, we go into hospital infection control. Hospital infection control, previously we have had about 9 standards and 51 objective elements. That has been slightly increased to 54 objective elements. So what was there previously as 9 has gone as 54. That's all what the current this thing is. Now, where the changes have been made, the changes are especially in infection control manual, there is an objective element added. Then in case of surveillance activities, sterilization, there has been some changes in the objective element, addition of objective element. So in the intent of the chapter, there has been some slight modification. Para 1, line 1, instead of an effective infection control program, it has been changed to an effective healthcare associated infection prevention and control program. The new paragraph has been added that in para 4, the organization has an effective antimicrobial management program through regularly updated antibiotic policy based on local data and monitors its implementation. The program also includes monitoring of antimicrobial usage in the organization. Now, summary of key addition, HIC 1A, those marked in bold are the place where changes have been made. This change has been made to bring in better clarity. Now, the policy and the interpretation that the objective element states as above, hospital infection prevention and control program is documented, which aims at preventing and reducing risk of healthcare associated infection in all areas of the hospital. Interpretation, the policies and procedures shall be directed at prevention and control of infection in all areas of the hospital and includes its monitoring. The organization shall have hospital associated infection prevention and control manual that shall incorporate the structure of the program, all processes, activities and surveillance procedures related to the program. In a nutshell, there has been a little more clarity which has been brought in, and that's the addition in HIC 1A. 1B, in the interpretation, risk reduction goals and measurable objectives are established by the committee at least annually and reviewed on monthly basis by the infection control team. So that again has been added for better clarity, and this also to some extent raises the bar from the existing standards. Next is on 1B. The hospital has an infection control team which coordinates the implementation of all infection prevention and control activities. The modification is that the team shall at least comprise of the ICO, ICNs, infection control officer, infection control nurse, infection control team staffed according to the hospital size, level of risk, and program's complexity and scope. So when we go for an audit or when we even implement it, don't ask for specific numbers which you think is important. More importantly, if they tell you that so many infection control nurses are there or so many infection control team people are there, ask them on what basis you have come to such conclusion. So that may be a better way. This has been added to reduce the ambiguity, some ambiguity which was there in the previously based on assessor feedbacks. 1E, interpretation is those who are knowledgeable in infection control practices. It is this shall be a doctor. What we have said is it should be a doctor, but he should have knowledge in infection control practices. And it is preferable that he or she is a clinical microbiologist. In the absence of a microbiologist, a surgeon physician can be designated as an infection control officer. The responsibility of the infection control officer are defined in the privileging document. So, points to note is it is preferable to be a clinical microbiologist, and it is not a mandatory requirement. But if anyone else is there, he has to have some reasonable experience or knowledge about what he is supposed to do, and it should be a part of the privileging document. So the interpretation is for a better clarity. Next is on 1F. Here, the change is that the responsibilities of the infection control nurse are defined in the privileging document. So again, this also goes into the privileging document. Next is on HIC 2. The organization implements policies and procedures laid down by the infection control manual in all areas of the hospital. So here there has been a slight change in the standard, again to reduce the ambiguity. The HIC 2A, the change in the interpretation is infection control program shall include all areas of the hospital, and the manual should clearly identify the high risk areas. So the program should control all areas, and within that you also identify the high risk areas. So again, this is to reduce the ambiguity which is there, probably to bring in more clarity. Next is on HIC 2D, the organization adheres to transmission-based precautions at all times. There has been some mild modification in interpretation. Personal protective equipment to be used in various situations of patient care are identified and used appropriately. Again, this has been added to bring in more, bring in more clarity. Also, please note objective element 2D has been interchanged with objective element 2E so that the flow is better. So you start with one and then go to transmission and then next one. So it's just that it is not that the order has been changed so that there is a better flow. 2F, the organization adheres to cleaning, disinfection, and sterilization practices. So the interpretation has been expanded for better clarity. Organization shall identify various different disinfectants being used in the patient care areas. Disinfectants use is identified and monitored. The common disinfectants used are identified, dilution protocols are established, and its usage in appropriate situations is complied with. Risks and hazards due to the usage of disinfectants are identified, and the staff is aware of these risks and hazards. This can be done through display of material safety data sheets of such disinfectants, and staff are educated through the MSDS. So here again, expansion for better clarity. And HIC 2G, appropriate antibiotic policy is established and documented. So this has been modified, to reinterpreted to bring about more uniformity. Next is on 2H. The organization implements the antibiotic policy and monitors rational use of antimicrobial agents. So here again, this has been bifurcated from 2G so that there is, and new objective element is added. So this basically is to raise a bar. So because you didn't want to club too many things at one go, one is there is more clarity. Suppose sometimes someone may be fulfilling part of it. When both are clubbed, sometimes they fulfill part of it. So you may give a partial. If you make it separate, they have to address both of them. So this is also to raise the bar. The interpretation here is the organization shall identify clinical conditions in which antimicrobial agents shall be used in terms of the type of antimicrobial agent, monotherapy versus combination therapy, escalation and de-escalation of therapy, dose and duration of antimicrobial therapy, deviation and dose and duration of antimicrobial therapy. Deviations are brought to the notice of the concerned clinicians, and corrective and preventive actions are taken and documented. So I'm just giving an example, which commonly we use. Say a patient comes with fever, altered sensorium, or a fever with suspecting an enteric. No harm in starting ceftriaxone straight away, because we don't want if you think that is appropriate. You don't want a meningitis to get worsen, or you don't want an entry to be untreated. Pending blood culture reports or pending Vidal reports and so on. And once you get these reports, and then if you find, or you get some alternate reports which confirms the diagnosis for which this antibiotic may not be required, then you may have to de-escalate it. Or if you find something different, you may have to change it. Or if you find that this was appropriate, you have to continue it. So in some situations, we may still have to start it, but continuation will depend on further things. So the rational use at the first instance of starting may be fine, but continuing indefinitely without a reason may not be fine. Next, the organization adheres to the laundry and linen management processes. Here, there has been a modification. Organization shall have a defined process for handling linen in patient care units during transport and inside the laundry. This has been added for by improving the clarity of the interpretation. Organization adheres to kitchen sanitation and food handling issues. Kitchen sanitation measures are implemented to prevent risks of cross-contamination, and this includes periodic cleaning of kitchen workers and food handlers for carriage of parasites and salmonella typhi every 6 months, or if the staff rejoins after a break of more than 15 days or more. Some of this may have a little difficulty in implementation. What we have to look at as an assessor would be to look at how organization is progressing towards this manner, and those who are implementing, you have to start on this so that you will be able to achieve it at some some predefined interval. So many times some of these may not be possible always on day one. There has to be a clear path. Organization adheres to housekeeping procedures. So next is what has been added is brooming and dry dusting of any sorts in that the clinical area should be avoided. This is based on good practices, and this is again to bring more clarity on what should not be done within clinical areas. Next is on HIC 3E, surveillance. So the compliance levels shall be shared with the relevant staff. So that has been added. That again it will be to raise the bar so that they know where they are or what they need to do. HIC 3F, surveillance activities. So here again, the new objective element has been added. This is again to raise the bar. So surveillance activities include mechanism to capture the occurrence of epidemiological significant diseases and multi-drug resistant organisms and highly virulent organisms. So this is a new objective element added, and this is part of the surveillance activity, which should also include capturing of drug resistant, multi-drug resistant and highly virulent infections. The organization shall closely monitor occurrence of multi-drug resistant organisms, example MRSA, multi-drug resistant gram-negative bacteria, and monitors of any suspected emergence and spread of infection with such microorganisms. The whole idea of the standard is there is an opportunity for you to monitor and make appropriate corrective actions if the occurrence level goes beyond the what is international levels. Next is HIC 3H, appropriate feedback regarding healthcare associated infections. Rates is provided on regular basis to appropriate personnel. So here the change has been that including data from other surveillance activities has been added, so that there is this brings in a lot more focus on surveillance, and it will also give data from other areas which will make it more comprehensive. Next, some of the other changes which has been done is in HIC 4A, organization takes action to prevent catheter associated infection. Organization takes action to prevent by ventilator associated pneumonia, and takes action to prevent central line associated bloodstream infection. HIC 5A, adequate and appropriate personal protective equipment, soaps and disinfectants are available and used correctly. So here the last line has been added. The staff use PPE as appropriate to the risks involved. The PPE are removed as soon as the purpose is served. Basically, you don't want to have someone wearing a glove and you touching the handle, opening the door, opening the doorknob and everything, and then the next person getting infected. So that's why it has to be removed after the intended purpose is over. Next is on isolation barrier. So this again has been modified. So isolation and barrier nursing facilities are available. The organization shall define the conditions where isolation is required and the conditions where barrier nursing or both are required. The same shall be carried out. The organization shall ensure that it provides the necessary resources to carry out the activity. And ideally, patients requiring isolation should be placed in isolation rooms, and airborne cases be kept in negative pressure rooms. The doors in the aisle of the other rooms should be kept closed at all times. Appropriate signage shall be used or displayed. 7C, reprocessing of instruments. So this, after a lot of deliberations, we made it as simplified as possible. So this is a reprocessing of instruments and equipments are covered. There is a documented process to address cleaning, disinfection and sterilization of accessories, instruments and equipments between patients. So this, that is between patients, means between various patients, how the reprocessing is done. This has to be clearly defined and followed. The organization shall have a documented policy and procedure for reprocessing of devices where applicable. So this is a new objective element. Just for a clarity, the other one is reprocessing of instruments and equipment are covered. For example, you use a endoscope. So that comes under, after using an endoscope, you need to reprocess that equipment or instrument before you use them on the next patient. So between the patients, what you need to use, how long you need to keep, that comes under here. Whereas this is for reprocessing of devices where applicable. So wherever you want to, the devices where you need to reprocess them, that is something where it is here. This is this objective element is used. The organization identifies those devices which are meant for reuse. So first you have to identify them, what are meant for use. Typical example is in the cardiothoracic is this octopus, or even a catheter which you want to reuse or which could be reused. The number of reuses and the process for reuse of these items are defined and monitored. The patient is informed of the same. Documented policies and procedures shall be in consonance with available good practices. Again, as I said, this for this particular objective element, I think there has been probably about 10 or 15 man hours spent to get this through, but this is required in because this is some practice which is followed in every hospital or many hospitals or most hospitals, and there has to be a process so that these aspects are identified. There is a process to keep patients informed and so on and so forth. Next is on appropriate personal protective measures are used by all categories of staff handling biomedical waste. So here the interpretation has been slightly modified for better clarity. Staff handling biomedical waste shall be provided with personal protective equipment, and the staff shall use the personal protective equipment while handling the waste. There has been a little change there. Now, key deletions. So what has been done is this is not actually, this has been, the sentence has been removed for interpretation from the interpretation. So, and because an air conditioned single room with an exhaust fan or a well ventilated room, an adequate option for a healthcare facility without negative pressure room. And if air conditioned single room is not available, a fan can be placed in the room to direct flow towards the outside window. This has been removed. Now, so overall, what is the impact of the improvements or what changes which has been made in HIC? The whole idea is to promote development of risk reduction goals for hospital-associated infection, clinical privileging of ICN, and also empowerment of ICNs has been addressed, rational and safe use of disinfectants, enhanced participation of stakeholders by sharing of hospital infection control data, promote rational use of antimicrobials and monitor its usage, improved infection control in kitchen, monitoring the multi-drug resistant infections and contaminant due to multi-drug resistant organisms, improved patient safety due to predefined informed reuse of the devices which are reused. So with this, I think we come to the end of the HIC, and then the next one will be on CQI. I think after that we can go for the continuous quality improvement. All of us are very well aware of this chapter. Now, what has happened here is that, just a second, from 8 standards it's become 9, and a total of, from 57 objective elements it has become 59 objective elements. We'll straight away go into the standards. So as I said, same formula here, either to improve the level, raise the bar, or to bring in more clarity, remove ambiguity, or merge with others where applicable. First will be with additions, then will be deletions, and then summary. So CQI 1A, this has been modified, the interpretation to bring in more clarity. The quality improvement program is developed, implemented, and maintained by a multidisciplinary committee. So this committee shall receive inputs and significant deliberations from other committees of the organization. See, what happens is, all committees were functioning. There was no standard, or there was nothing in the standard to address the coordination of committees, or one place where the findings of various committees are discussed. So we thought that may be appropriate to be in the CQI, and that is why this has been put. So which means the quality committee also reviews the significant findings of various committees and incorporates them into their processes or changes in policy, or as part of their committee deliberations. Quality improvement program is documented, which is comprehensive and covers all major elements related to quality assurance. So here, this has been, the interpretation has been modified, where the following has been added: frequency of mock drills, audit schedules, committee and terms of reference, review policy, and implementation of corrective and preventive action. The quality assurance program for specific areas like laboratory, imaging, operation theatre, environment, and ICU is also summarized. So this has been added. 1B, the quality improvement program promotes and demonstrates use of innovations to improve processes, efficiency, and effectiveness. So here what has been done is, this is a new objective element. Portion of the earlier objective element merged with the CQI 1B, and a part of it is bifurcated, and which is here. So this is also one, is to bring in little more clarity and merge common areas, and also to raise the bar. Now this again, when this objective element was introduced, there was a lot of deliberations. Don't confuse innovation with invention. So innovation does not mean that something new has to be invented. So innovation, it could be that you are doing the same process in a better, more efficient manner. So that's quality is all about improving, and innovation, if you improve process, that could be one of the innovations. So please look at it on the whole context, and not to be confused with invention. So it's not that you are bringing in something new and saying, okay, so it could be that, okay, my patient registration has been like this. Now I have simplified the process so that as soon as the patient comes, within 30 seconds, he gets it done. That could be an innovation. So look at it in the whole context. Interpretation is that the quality improvement program encourages the use of novel strategies to improve both clinical and managerial processes. The impact of the managerial processes, innovations, may be at the level of departmental or hospital-wide innovations, may be targeted to improve patient safety, care delivery, reducing costs, introduce environment-friendly measures. The management of the organization promotes these innovations. The designated program is communicated and coordinated amongst all staff of the organization through appropriate training mechanism. Staff are made aware of the structure of the quality assurance program in the hospital. Staff are also aware of these individual roles in contributing to the quality assurance program as a part of their job description. So this has been modified for better interpretation. CQI 1F talks about quality improvement program, identifies opportunities for improvement based on the review of predetermined intervals. So here the objective, the interpretation has been modified. Quality improvement program is a dynamic process. There is an outline of periodic review mechanisms at different levels such as department, senior administration, management reviews, etc. And the quality improvement program needs to be reviewed by the quality improvement committee as regular predefined intervals as defined by the organization in the quality improvement manual, but at least once in 3 months. Review shall include, so here you see that the review has been once in 3 months. Review shall include focused audits, organizational performance analysis of key indicators as identified and determined by the organization, including the matter which is laid down by the CQI. The minimum meetings should be recorded and maintained. Quality improvement program is continuous process and updated at least once in a year. The interpretation for this has been modified for better clarity. The inputs for the updates should be based on audits and feedback mechanism. Again, what interpretation modified? This is also for better clarity and raising the bar. So audits, CQI 1H, audits are conducted at regular intervals as mean of continuous monitoring. Choice and frequency audit shall be defined for priority areas in the organization and for areas of concern as identified by trends, indicators, and identified risk, etc. So here, actually, what we are doing is we are giving a different dimension for the hospital to look at it. Now, so basically, if a hospital thinks one area could be audited, say once, say 3 months, but another area I'm having recurrent problems. I need to audit it every month. That is left for them. Again, when you go as an assessor, please don't look at saying that, I feel this is required. No, so you have to do like this. As long as the overall intent is met, we should not look at how they do it. Now, however, all areas of the organization shall be covered by a hospital-wide internal audit at least once in 6 months as per the schedule plan. So when we go, when we have to ensure that it is done at least once in 6 months. Or you can always ask, have you identified some areas where it requires more audit? What are the reasons? And how can you, if there were these things, how has been the progress? And so this is, you're giving the hospital a scope for it, look at it beyond the normal audits. The internal audit of a particular area shall include all the applicable standards and objective elements. And, so that is here. So this has been a change in the interpretation and also to raise the bar. There is an established process in the organization to monitor and improve quality of nursing care. The interpretation has been modified. This could also be in the form of a competency evaluation by a written questionnaire or a witness demonstration for key nursing procedures such as medication administration, peripheral IV cannula placement, tracheostomy care, etc. The organization shall identify key performance indicators that reflect excellence in nursing care. Now, this again has been modified to bring in more clarity. This is on patient safety program. It's developed, implemented, and maintained by a multidisciplinary committee. So, with the purpose of to protect the patient from harm, either from the environment or for lack of appropriate care or safety measures. This committee shall be called as a patient safety committee, clinical risk management committee, or whatever else it could be appropriate. And this is just, these two are just sample names. Whatever the hospitals say, they call it, say, a never event committee or anything that could be, but these are some representative names. CQI 2D this objective element has been modified in the interpretation. This talks about the scope of the program is defined to include from no harm to sentinel event. So here, what it says is with regard to the patient. So no harm to sentinel event with regard to whom? So that has been a little more clarified with regard to the patient. And say 2H has also been modified to include that updates could be based on findings of the audit and reviews carried out by the safety committee, etc. 3E, monitoring includes surgical services. So the sentence added is intraoperative changes in the surgical plan are also captured. So that has been added. CQI 3G, monitoring includes infection control activities. So again, here modification is it's all associated, catheter associated, ventilator associated pneumonia, central line associated bloodstream infections. And in addition, please note, this is something which has been added here after a lot of, again, deliberation. Now, it was deliberated whether there are, slowly, the world is moving from ventilator-associated pneumonia to ventilator-associated events. But I think, it's too preliminary. We have, for us, even people still don't understand clearly what ventilator-associated pneumonia is. So they also, sometimes even they take a community ammonia which comes to the hospital as ventilator-associated pneumonia. So in this, after deliberations, it was decided we will still continue with the ventilator-associated pneumonia. But for an organization, where they've already reached to want to go to the next level, we should also introduce this term of VAE. So what has been added is, in addition to capturing ventilator-associated pneumonia, the hospital shall also make efforts to monitor ventilator-associated events and for the definition of this, you could look at CDC guidelines. So that term has been brought in here, and it's better that we start looking at it. Say, for example, pneumothorax could be due to a ventilator, could be a part of ventilator-associated event, whereas if it's not captured if only ventilator-associated pneumonia is there. So these are some of the things. It could be VAEs. Term is introduced. So again, when going for an assessment, as long as people are aware, they have started working on it, I don't think we should go deeper into it because that was the whole intent. Monitoring includes patient safety goals. So in this is a new objective element, and this is clearly to raise the bar. So patient safety goals has been added. So here, organization shall monitor the following patient safety indicator: incidence of communication errors, including handovers, incidence of patient identification errors, compliance of hand hygiene practices, and compliance rate of medication prescription in capitals. Other patient safety indicators based on international national patient safety goals may also be identified and monitored based on the internal prioritization within the organization. So again, it's not going to be easy. This is going to take time. All we have to see is whether the organization has started, working towards this. The organization identifies and monitors priority aspects of patient care. So this is a new objective element added to raise the bar. The organization may choose to monitor other clinical indicators in relation to the key steps in the evaluation of common disorders, treatment protocols, and outcomes. A minimum of 4 such indicators shall be monitored, and these indicators are based on available literature created in accordance with good practices. Example, compliance with order of antiplatelet agent in MI patients or discharge, or to do first dose antibiotic in a patient with admitted with septic shock, timely cessation of antibiotics for surgical patients, cesarean section rate, pain relief following intervention, etc. So you identify and monitor at least four aspects which is of priority for patient care. Again, another new objective element which has been added is the organization identifies and monitors priority managerial activities with the organization. So here this was priority patient care activities, and then this has been a priority managerial activities. Examples could be act for dispensing medications, non-availability of consultants when on call, timely refilling of fire extinguishers, etc. So indirectly this could also be of patient care, but predominantly it's why we put this is from the managerial side also. There has to be a few things which they prioritize and look at it. CQI 5, new standard, and this is to raise the bar and also the consolidate the objective element of CQI 3 and 4. There is a mechanism for validation and analysis of quality indicators to facilitate quality improvement. There is a mechanism for validation of data. Now you have a data, they give you a data, they say this is what. There is, right now the standard does not provide for any scope for it to look at whether the data is valid. Indirectly it could be looked at, but there is no direct representation in the standard. So this is a new objective element which is to bring in more, bringing better clarity and probably making it more easier for the organization to adhere to. The data which is collected is validated from time to time and in response to queries or when on unexplained trends occur. 5B, there is a mechanism for analysis of data which results in identifying opportunities for improvement. 5C, the opportunities for improvement are implemented and evaluated. All improvement activities carried in the organization shall have an evaluable outcome, basically this, and this shall also be, the same shall be captured. 5D, the organization uses appropriate quality improvement statistical and managerial tools in quality improvement program. Whenever possible, the appropriate principles of methodology are used, that has been added. 5E, feedback about care and services communicated to the staff. So that again, at interpretation, at a minimum patient satisfaction level shall be communicated on a monthly basis, and this should be done using internal mechanism. CQI 6A, so this is a new objective element added to raise the bar. The leaders at all level of the organization are aware of the intent of the quality improvement program and the approach to its implementation. So here the whole idea is that the top leadership will have to be involved in the quality management, in the quality improvement program. Otherwise, it is just left to a few people to look at it and decide what it is required. The organization and the departmental leaders are aware of the quality improvement program, its intent and applicability to the respective areas, and how it contributes to the organization as a whole. 6C, changes that the next year's budget is discussed and noted in the quality core committee and by the top management, that has been added. Management identified the CQI 6D, so that has been modified. The management identifies organizational performance improvement targets, so which is said at least once in 3 months has been introduced. The parameters to be audited are defined by the organization. The organization shall identify and work on at least 4 clinical audits in identified priority areas, priority care aspects. All these audits are, as these audits are retrospective or concurrent in nature, it is imperative that this be done using predefined parameters so that there is no bias. The parameters could be disease-based, cost-based, community-based, so that has already been there. The only thing which has been added is at least 4 clinical audits it has to be identified and work on it. So till now there has been no definition of numbers. So someone does 1 clinical audit between the first assessment and the re-accreditation, they could still get away. So here minimum of 4 has been defined. So here also please note that identify and work on at least 4 clinical audits. So at this, at any point, there could be a concurrent 4 clinical audits, or you could, that's what it means. So you could say, I have an audit cycle, say of 1 year, and I am doing 4 audits on this year, which is fine and acceptable. Incidents are collected and analyzed to ensure continual quality improvement, and that has been there has been a small modification. And CQI 8B is also analysis of incidents has been added. 8D, new objective element, the organization shall have a process for informing various stakeholders in case of near miss or adverse event. So now a near miss happens. There has to be a way where relevant people are informed. So the standard has provided a scope for you to address this. After due analysis, an incident could be termed as a near miss or an adverse event. Based on the nature of the near miss or an adverse event, the organization shall inform the various stakeholders regarding relevant concerns in addition to initiating corrective and preventive actions. Now, how do you inform? What do you inform is left to you, left to the organization policy, based on which, and some based on some good practices done elsewhere. Some of them are very difficult. We can't be prescriptive because there is a lot of it is based on cultural, lot of it is based on understanding, educational level, people whom you are talking, and so on and so forth. So, but the standard provides a scope for you to address this. Next is on 9B. Interpretation has been modified. That is, this is for corrective and preventive actions are taken based on the findings of such analysis. The interpretation has been modified for a better clarity. So, summary of key deletions is that one is on CQI 2J. The organization uses at least 2 identifiers across the organization. So, this has been deleted due to implicit coverage. The other thing which has been deleted is CQI 3J. Monitoring includes data collection for support for further improvements. This has been deleted and it has been put in a different format in the validation of this thing. And see, because these two are always pain points, CQI 3J and K, 4H and I. So that has been deleted and put in a different format, which is more easier to adhere to and also to audit. So that is how it has been put in a different format. Others are CQI 5D, the management supports and implements use of appropriate quality improvement tools, statistical tools. So this has been shifted to 6, for COP 6. Organization has a process to collect feedback and receive complaints. This is because it is already covered in PRE 7, so this has been deleted. Feedback about care and service is communicated to the staff, and this is replaced with a new objective element. So the overall impact is that the quality improvement program to cover important departmental QAs were specified, mock drills, responsibility of leadership has been strengthened, innovation has been added, process efficiency has been addressed, effectiveness and environmental friendly measures has been addressed, competency evaluation of courses has been added, and then the monitoring of PSG's incidents of communication errors has been has been added. Additional monitoring of clinical and managerial indicators for each has been added, and then validation and analysis of quality indicators has been added. In addition to feedback about care services given to the staff, tracking of results of improvement, use of quality improvement tools like FEMAs or RCAs, and then departmental leaders' awareness and their responsibility, and feedback about incidents given back to the staff and various stakeholders. So I think with this, we come to the end of the CQI modifications in relation to the standard 4th edition of the NABH standard.
Dr. Murli?
Yeah.
Yeah, thank you, Dr. Murli, for the enlightening session. It was very informative. Now we will take question and answer question from the assessor, and you will guide them. So first question I am taking from Vasundhara Atre, and her question is, what kind of data validation are we looking at?
Can I, how do I open the video or something? No?
Sir?
Video can I open?
No.
No? Video doesn't come?
You can hear me, sir?
No, see, I can hear you.
Yeah.
You can answer like this or video comes?
No. You have to answer like this only, sir.
Okay. Right. So basically data validation. What are we looking at?
Yeah.
Suppose someone tells you that this is my infection control rate or this is my success rate in a particular procedure. All what we are going to look at is how are you looking at it? What are the procedures? How are you capturing the data? If you want to know whether that data, the number is robust or not. So the number, is it correct or not? So the organization has to mechanism to see how those numbers have been captured. So as an assessor, what you will say is, okay, how did you get this data? From where? You could do a sampling, do an audit trail and see whether that data itself is correct or not. So from implementing the standard point of view, the organization, any data which it takes for analysis, it has to be clear how the data has come, how it is captured. So it could be a sampling, it could be that every patient is captured. In that case, who captures it, where it is captured. So these has to be specified. That is how data validation is.
Thank you, Dr. Mulli. Now the second question I'm going to ask from taking from Antonia P. Miss Antonia P, can you hear me? You can ask question directly to Dr. Mulli.
Antonia, madam.
I think she cannot hear us, sir. I'm just narrating her question. I'm just narrating her question.
Yeah.
Yes, sir. Is it possible for us to refer, though we have benchmarking from SHEA, WHO, CDC, MHFW? We do not have benchmarking for all the quality indicators. The Indian benchmarking will help the assessor and SEO to refer. Please guide us.
So as long as you don't have any, whatever Indian benchmarkings are available, you could look at that, number one. Number two is, whenever you're looking at benchmarking, you also have to be clear from where you got it. So if you don't have it, you could, there are two ways of looking at it. You could have international benchmarks. Now, sometimes if you feel it is not relevant, your own benchmarks could be there. What is your last year's performance? So you could have three things. You could have international benchmark, what is your last year's performance, what is your current year, and what you think is appropriate moving forward. So yes, it's good that if we can have all benchmarks for India. I think NABH is working to try to get a few of them. But that is why this new standard has been introduced on validation of data. So sometimes even we are not sure. Someone sends an infection control saying that it's 0. It's difficult to say whether that is right or wrong. So the answer is, look at available Indian data, look at international data. Your own data could serve as your benchmarks.
Thank you, sir. Thank you very much. The next question is from Vimal Kumar Govindan. His question is from CQI 3E 1 and 6. Percentage of unplanned return to OT and re-exploration rate.
What's the question?
So the question is percentage of unplanned return to OT and the re-exploration rate.
Okay.
CQI 3E 1 and 6.
If the intention of this question is this, how do you calculate this? You define what is unplanned return.
Yeah.
So if the patient is not, destined to go to the OT, so you could say that this could be within 24 hours or which is not intended to. And if this happens, you take that and then the formula is already given. So you capture each one of them and then use the formula and take it. That is the question intended. The question is not very clear.
Okay, sir. Thank you very much, sir. The next question I am taking from Mir Khan. Mr. Mir Khan, you can directly ask your question. Please, go ahead.
Sir, can a pathologist also be a part of the infection control committee?
No. Yes. See, let's go into a deeper thing. I'll ask you one question. Can a pathologist sign microbiology reports as part of NABL? Okay, I didn't get your this thing. So if your answer is, can pathologist also be a part of the infection control team? The answer is, it could be, provided the person has requisite knowledge or training and knows what his or her role is going to be.
Okay.
Thank you.
Thank you. Thank you very much. Sir, the next question I'm taking from Mr. Rajiv Shaurya.
I want to be very specific on this. Your question was, can she be a part of the committee? And my answer was for that.
Okay. Sir, kindly elaborate more on data validation, Mr. Rajiv Shaurya. Again, the same question.
I think, as I said, this is whatever I told you on that is very in a broad-based manner. Probably, I think there are few you say, articles on data validation which has come up. And if there are more requirement, I think probably this could be, this itself is a small webinar which probably should come in. But in a nutshell, what we meant, what in a broad, what you meant on data validation is, you want to be sure the data what you are getting is correct and true, and not a false data.
Okay, thank you very much, sir. Next question is from Dr. Akash Sood. Dr. Akash, can you hear us? Dr. Akash?
Yeah.
Yeah, you can ask your question directly to Dr. Murli. Go ahead.
So, Dr. Akash,
I wanted to know the 4 clinical audits which are required. Are the 4 clinical audits to be presented during assessment, or they have to be done in one audit cycle? If in one audit cycle, is the audit cycle 1.5 years, or is it to be 3 years?
okay. No, I'll tell you, see what it was meant is at any point of time there should be at least 4 concurrent audits should be there. So at the beginning of the audit, you will always define the audit size, time, and this thing. So yes, that part I also noticed that there can be various ways of interpretation. But to make it simple, I would say that between the 2 audits at any point, there should have been at least 4 audits which has done. So maybe I'll give an example. Now, the final assessment is over. Between that and the next accreditation cycle is coming. You have started 4 audits. That 2 are over. 2 are still ongoing. We have another 2 more months to go. But that still fulfills the criteria.
Okay.
I hope I have clear. I'll give once more the example. Final assessment is over. You're going for a surveillance. At the time of surveillance, between the 2, you've been doing say 4 audits. At that point of time, 2 are over, 2 are ongoing, and you have started 2 more audits. Okay. So at any point there should be 4 audits. Can we read the standard once more? That is just that's what it means.
Okay, thank you, sir. Thank you very much. So the next question is from Sandhya Shankar Pandey. Her question is that, is it necessary to release specific privileging forms for ICO and ICN in the hospital in spite of they being issued specific job description and designation letter and certificate?
It is very simple. What it means is, in their personal files, you also say that they have been privileged for this. That's all what you need. Whether you do it in a form, whether you do it in a letter, that's left to organization.
Okay, thank you, sir. I think we are done with the question and answer session. Sir, one more question is from Dr. Rajiv. Dr. Rajiv, can you hear me? Dr. Rajiv?
Yeah.
Yeah, you can ask
Hello.
your question. Yeah, you can ask your question, sir. Hello?
Rajiv,
Yes.
Go
My
ahead.
question is,
Yeah.
regarding validation of data. Once again, I am just how to check the accuracy of the validation of the data. Data is accurate, false or right is okay, but how to check data is valid? Accuracy. What is what will be the cutoff? 60%, 20%. If I am getting accuracy, it will be validated or not validated. What will be the cutoff percentage?
that's what I said here. What we are looking at, and as I said, I'm not going into a depth of it. That's a separate thing. What you are looking at is, suppose you say that my consent form, compliance is 90%. So what we are going to look at is, how do you say that it's 90%? How was the data captured? And how was it validated whether the data what you captured is correct? So what happens is, you look at the process and see whether the process has been correct, whether the validation has been right. Now, that is what you're looking at. So I'm just giving a very broad view. Broad view is that you are looking whether, when I say 90%, that has to be there can be 2 ways of this. One, I collect all my sample auditing, all my consent forms, and look at all data in that. The second way of looking at it is, maybe I will say I do a sampling. 20% of my sampling I do, and I look at that. So whichever way I have adopted, then I have to have a way where this data could be validated. So as an assessor, you have to see whether whichever way I have adopted, whether my data is validatable or not. Now, as I said, for more further clarifications, there has been some write-ups, and probably I think this is something probably the NABH is also considering to have more probably documents to have further clarity. But in a very broad spectrum, you're looking at whether the data what you get is correct. Suppose you say that, okay, no, I have done only, say, and that's why it also looks at the overall thing. Suppose someone says that 1,000 patients have had a surgery, I looked only at 10 consent forms, and based on that, I have 90%. Now, from that 10 consent forms, maybe that is right, but overall data is no validity because it is not taken on some statistical principles, and that per se may not have a validity. So that is what you are looking at. So one is what the process, whether they are correct or not. Okay.
Yes. So only one. Who will give clinical privileges to ICN and infection control officer? Mostly we are looking. Who will give? Who has a power to give clinical privileges?
Or head of the organization, based along with the HR, based on what they're equipped with, their experiences, what their qualification, experience, training, and based on various factors, they would also designate them as a this thing. So basically, here what we are trying to do is, now someone will be privileged. So here someone will be made as particular. Here, when there is a privileging, definitely you look at some criteria before you privilege them. So this is again giving a scope for the organization to look at that.
Okay,
thank you, sir.
Thank you, sir. Thank you very much. Sir, sir, वही हो गया उन्हीं का. Dr. Ashutosh Sharma. Dr. Ashutosh.
Yeah. Hello. Hi, sir. Good evening. Am I audible?
Hello. Hi, Dr. Ashutosh. How are you?
Was fine. Thanks. I just wanted to see this last point that we covered, that is intimating regarding adverse events and near misses to the stakeholders. Now, in any such event, the first stakeholder would be the patient and the family.
Correct.
Are we looking at that, or are we looking at only as a teaching mechanism for our staff?
We are also looking at that. So, I will not say we are only looking at that, or we are not looking at that. We are also looking at that. Now, that is why it has not been very explicit, because based on this has to have, this is right now, it is for the organization to give a thought process to it. Many times today we are not prepared for it. It is for the organization to get prepared. All what we need to know is errors can happen. Things can go wrong. But when it goes wrong, how do we address it? One is how do we clinically address, how do we communicate to the patient, how do we do it, what do we do it, and that is, which is internationally and well accepted terminology. See, I'll just give a very quick example before I this thing. That's why in India the cultural things are there. When I went, recently when I went for some educational trip, abroad, I was told by a doctor that they disclose to the family that as long as the family knows that yes, this went wrong or that went wrong, most of the times they say, okay, yes, in a healthcare facility it can go wrong, and I am happy that you disclose this, and they don't. But I don't know whether a scenario this could be similar in India and extrapolate. So how are we going to communicate? So that is what this also comes under the term of something which is I would say difficult situations to communicate. So if you're going in communication, there is also an indirect link to it. So it very well includes patient, but at this point of time, it is left to the organization to decide how they are going to do it.
Maybe a little maturity over time, or it may not be a mandatory criteria, maybe something desirable, some step towards it.
No, we have to make a step towards it. So sometimes it could be baby steps, then get a bigger step, but we have to start this step. And this is something which we can't run away from. But as I said, this is again to raise the bar.
Thank you, sir.
Okay, thank you, sir. Now we are ending the question and answer session. I think we have given all the queries. We have all addresses all the queries. So thank you, Dr. Murli, for your enlightening session and the wonderful explanation of the questions. And the next webinar, the next session will be announced soon, and it will be invitation will be sent to all the assessors again. Thank you very much for your time and your patience.
Thank you.
Thank you, sir. Thank you.
Thank you all. Thank you, sir.
Thank you.
Thank you, Dr. Kalra, sir.
Thank you. Thank you. Thank you, Dr. Murli, for wonderful session. Yeah.
Thank you, sir. Okay, sir, it went off. It went off well. You know, I was some things did not come.
Yeah. I think overall it was good. And we have to make a request. All assessors, they should attend. Yeah. ब्रॉडकास्ट बंद कर दो, गूगल से चलने दो बात. Hear me?
Yes, sir, I can hear you.
Yeah. Broadcast.
If we do it more often, probably we'll get used to it, I think, sir.
Yeah, probably little more.